everyone. Thanks for coming, everyone. I'd like to welcome Dr. Madeleine Muller. Dr. Muller is a family physician with CMH and Walter Sisulu, and she's the coordinator of our local HIV Clinicians Society. And her presentation is as such, the Gender Affirming Guidelines in our healthcare. And, I wasn't aware of it. I was talking to two colleagues next to me in the row, and like this, and this is, something which is fairly common knowledge and commonplace sort of medicine for a lot of the endocrinology group and maybe pediatricians to a certain extent. But all of us in the Department of Medicine need to really get sensitized to this this key member or this key part of our society and the medicine that's involved with all of this. Gender affirming healthcare programs are up and running in most parts of the world, and the Eastern Cape is no exception. I was actually told that you have
there's a small,
there's Duncan.
But it's RHI. I'll talk about that at the end. Yeah.
And Dr. Van Heerden and my ex-partner, things like this, she's an endocrinologist, and also saying that she's got quite a number of patients in her practice and stuff, so that us in our Department of Medicine need to be sensitized to this key group of populations and what the actual medication and healthcare requirements are. And I don't think Frere Hospital is going to be a specific satellite.
We'll talk about that. Yeah, we'll talk about that.
But certainly, if we have one of these clients, patients arriving in our clinic and needing therapy or hormonal therapy, we need to know the facts and the figures. The HIV Clinicians Society has got a wonderful almost book on this. I downloaded chapter 6, which is the hormone therapy, and it really gives you a wonderful layout of exactly how to go about it. And also some very important parts of this whole journey that these transgender folk, these non-binary folk go through to reach this point that they need to make a change in their lives to the point of hormone therapy. That's a very important part of medicine, and it certainly gets a lot of news and coverage and things like this group of population, this group of our society. So I'd like to welcome you, and I think it's very much really time for us to learn.
Thank you very much. Good morning, everybody. Thank you very much for giving me this opportunity. And we also want to thank internal medicine, because there's quite a few other people, not just from CMH and family medicine, not just internal medicine, that's here today. We're very happy to have members of the private sector here. I can see pharmacists from DGDH here. So we're having, oh, there we go, we've got bits of RHI representation. So we have various people who are involved in transgender care in East London here today, and we'd like to welcome them all. So I'm going to talk about the Gender Affirming Guidelines that was published by the HIV Clinicians Society in October of last year, and was actually officially launched at their conference last year. Don't we all miss the days of conferences, right? These days you just do it online. And usually when I call people up, I've been chatting to various people in terms of we want to get together another, an actual in-person HIV clinicians event, maybe in June, July. And when you speak to people, the first thing they say is, gender affirming, what's that? And then the next question I get is, why on earth did the HIV Clinicians Society bring out a guideline on gender affirming healthcare? And those are the two questions we're going to be focusing on today. So to be able to understand why this is all happening, we don't need to take ourselves back to the National Strategic Plan, and we're going to look specifically at goal number 3, which is around key populations. So we are looking more and more, when we look at HIV care, we're pretty much able to run out HIV and STI and TB care to most of our population. But we know that there are particular key populations that are much more vulnerable than others, and that needs specific inputs. So in that particular NSP, they identified 5 key populations specifically for HIV, which is our sex workers, our transgender people, men who have sex with men, our people who use drugs, and inmates. And there are several government documents that's been developed around these particular populations. So there are comprehensive packages. So there's a strategic plan around sex workers, for example. There's an HIV and STI plan around correctional services. The HIV Clinician Society has been very involved. For example, they had a specific guideline for pre-exposure prophylaxis for men who have sex with men. So there's been lots of ways of looking at how do we target specific key populations that might have different needs than our sort of bulk normal public health programs. So the key message in that document is nobody gets left behind. And I always love this quote. I realize nobody seems to know exactly who said it, but the true measure of any society can be found in how it treats its most vulnerable members. So I think in public health, we're very good at looking how do we provide care for 95% of the people that come to us, but also how do we keep aware of those minority and vulnerable groups that might not access care for a variety of reasons. So we're going to speak just about the specific key population called transgender and gender diverse people. If you're slightly older and some of those terms don't seem a bit unfamiliar, don't worry, we're going to cover all of that. I think the young people, your students and our interns, these terms and these concepts are much more familiar. It's in our media, it's on our social Instagram posts, and I think our young people are much more comfortable with talking about transgender than maybe some of our older population. So just to clarify a couple of concepts. So sexual orientation and gender identity are two different things. So when we talk about sexual orientation, we talk about who you are attracted to. This little graph comes from a lovely a tool we call the gender taboo that we use when we talk to teenagers or people about sexual health and are trying to understand their sexual identities. And we look at who they are actually attracted to. And about 5% of the worldwide population are attracted to same sex. If we look at just a little bit back in history, it's just to remind us that until 1973, the DSM still considered homosexuality a diagnosis. And until 1992, it was only removed from the ICD. So these concepts were something that we used to pathologize in medicine, and we've now understood it as part of our normal diverse population. And even in South Africa, until 1994, homosexuality was still illegal, although that was not necessarily always, there wasn't necessarily prosecutions, but you could still get 7 years in prison if you went to court. And now, of course, we know in 94 changed, and now South Africa is one of the most progressive constitutions in the world regarding our LGBT communities. So the two concepts we're going to have to differentiate is biological sex and gender identity. Biological sex is what the midwife says when you are born. Oh, it's a boy, or oh, it's a girl, or oh, I'm not so sure. That's the intersex. And we call that sex assigned at birth. And there's sort of 7 characteristics that sets your biological sex. So what genitalia you have, are you an XX or an XY? Do you have ovaries or testicles? Do you have a womb? Do you make hormones? How does your body respond to hormones? And all of those secondary sex characteristics. So this classically we call biological sex. And it's interesting, South Africa has got some of the highest percentage of intersex per children born with intersex, almost the same incidence as twins. And there's more and more talk now also around the rights of intersex people in terms of a gender in their own right. But gender identity, and just the terminology. So when we talk about biological talk, the cool way of describing it is assigned male at birth or assigned female at birth. So gender identity is something different, and I'm using the definition here by the Yogyakarta principles that South Africa also signed up for. So it's each person's deeply felt internal and individual experience of gender, which may or may not correspond with the sex that they were assigned at birth. So here again from the gender taboo, and you can see it's not a line where on the one side, oh, you are mostly male, and on this side, you're mostly female, and sometimes you're across the spectrum. Actually, people have a certain amount of identifying with being a female, a certain amount of identifying with being a male. We're also going to talk about gender diverse. So there's a whole different mix. And when you do this gender taboo tool with people, it's amazing to see how diverse we all are in our perception of who we are, what we're attracted to, and how we consider our own identity. So some terminology. So transgender people means that you have a gender identity that's different than the sex you were assigned at birth. So a transgender woman, trans woman, or trans feminine is the term that we use, and I'll give some more examples in a moment, or a transgender man, trans man, or trans masculine. Cisgender is the majority of our population, which would say that we have the same gender identity that which we were assigned at birth. So the midwife went, it's a girl, and I also identify as being a girl. And gender diverse is a term to describe people who do not conform to society or culture's expectations of men or women. So actually, it's amazing to see how many different descriptions there can be of gender and types of gender out there. I know in the Native Americans, they have something called two-spirit, where you have both the spirit of the man and the woman. And so there's lots of different terminologies out there around gender diverse. So transgender women. So here's some of our famous transgender women. That's Laverne Cox up there. Any of you that's watched Orange is the New Black. They were assigned male at birth. So the midwife went, it's a boy, but they identify as a woman. And one of the ways that we then, where you would describe your gender. So for example, I was at the World Association of Sexual Health conference in August last year, virtually, unfortunately, but it was from Cape Town. The first time we had was actually in Africa. And when you introduce yourself, you would introduce your pronouns. So you would say, I'm Dr. Madeleine Muller, this is who I am, and my pronouns that I prefer to use is she. So that is an easy way to both express your gender identity and also to ask somebody about their gender identity. So if you're not sure, you can just say, which pronouns would you like me to use? And this is a local Machaba, who was one of the first trans women to make the top 30 of Miss South Africa. So transgender man is somebody who's been assigned female at birth. So it's a girl when they were born, but they identify as a man, and their pronouns will obviously be he and him. So up there, he was in Spider-Man, the guy in the top corner, Zach Barach. Michael Smith is from sort of one of the biggest, one of those series in America. And this is one of our local, I need to get my buttons right. Hey? This is one of our local transgender men, Nox Similane. He lives in KZN, and he's become a YouTuber, and he documented his transition process on YouTube in South Africa. So he's been one of the men who's been very visible in the transgender world in terms of transition and understanding transgender issues. Oh, and that's one of a male model from England who has appeared on the front of the Gay Times as the first transgender man who appeared on the front of the Gay Times magazine. So the third concept is non-binary, gender fluid, gender queer. Those concepts are not actually interchangeable. When you speak to different people, they'll have different definitions of what exactly those mean. But basically, it's a range of gender identities that do not fall in the traditional binary categories of male or female. So you might have somebody who says, I'm quite androgynous, I don't feel either male or female. Or you will have somebody that says, well, sometimes I'm all male and sometimes I'm all female. Or you can have somebody that says, actually, I have both very strongly. So there's a whole lot of different mixes in that. Zanele Muhole is an amazing photographer, has done an exhibition, a photographer that's done exhibitions at the Tate Modern. They were at the Grahamstown Arts Festival a couple of years ago. We actually saw one of their exhibitions, and their pronouns that they use, which takes a bit of getting used to, is what we call the singular they or the singular them. So when I talk about Zanele, I will refer to them as them. And it's a singular. It's a bit like when you say, if you give the child sweets, they might get sick. So you're actually using a singular pronoun to refer to somebody. And it's not related to a specific gender. So another concept which does not really fall under TGD, but it's good to be aware of, is gender expression, which might not be anything to do with your gender identity. So you might feel like a man, but today you might identify as a man, but you might like to dress like a woman on some days. So not all drag queens, for example, are necessarily transgender. They might just like to gender express in that way, but they identify as a male. So this is Jonathan Van Ness. I don't know if any of you watch Queer Eye. That's at the Emmy Awards. And this is an example of gender expression. So they're actually non-binary. And you can see you've got the lovely beard, which is the masculine expression, and then the gorgeous shoes, which I desire, which is more your feminine expression. So you have that combination of both masculine and feminine. So if we look at prevalence, the simple answer is we don't really have good data. So there's obviously very patchy data across the world. It's fairly stable that it's somewhere between 0.1% and 2% of the population. And then depending on different studies, you will have different numbers. It normally sits between about 0.5 and 0.7% of the population. And that percentage is fairly standard no matter where you're looking in the world. And we've got very little information about Africa. So if you ask me, what is the percentage of transgender people in Mdantsane? We have no idea. So there is, if you also, for example, even Stats SA, there's issues now that they don't have a place for you to mark a different gender or which gender you identify with. So how will we know what our populations are if we're not even asking that in our census? So important to understand is that it's now clear that it's a biological basis. It's not something that you choose. It's not a fashion. We know that gonadal sex gets established in the first trimester of pregnancy, but gender identity already seems to be formed in the second trimester of pregnancy. And it's a combination partly of genetics and partly a combination of prenatal hormones. So in genetic studies, there are about a 39.1% concordance for gender incongruence. So it's not only genetic, there's also other factors. But they've even had studies where they've looked at the brain structure. And what's interesting is that although the phenotypes of people with gender incongruence differ in different ways from control males and females, there's not a complete sex reversal. So it's not like you're born with a male brain or you're born with a female brain, but there certainly are differences than your cisgendered men or women. So what has happened in response to this evidence and this understanding of trans communities is what we call the depathologizing of transgender, and we had to do the same with homosexuality. But this has been much more recent. So in the ICD, under the ICD-10, it was called a gender identity disorder. So it was seen as a mental health disorder. And they changed that in the ICD-11, and this happened on 18th June 2018. That's very, very recent, where it was changed to gender incongruence. And this was adopted by the World Health Assembly on the 25th of May of 2019. And the WHO actually made a public statement to say that being trans or gender diverse does not mean you're suffering from a mental disorder. This is just part of our normal diverse communities like we have with homosexuality. And all of this now, both sexual orientation and gender identity, yes, is just seen as part of the human race, so to speak. DSM, it used to also be referred to the gender identification disorder, and they changed that in 2013, a little bit earlier than the ICD, to gender dysphoria. Now, this is one of those interesting discussions about why do we have these concepts actually in the ICD-10 and the DSM at all. So homosexuality does not appear in the ICD-10 as a diagnostic line, and certainly it should not need to be in the psychiatric manual. So gender dysphoria, we'll talk a little bit about later, is not a mental disorder, it's just an experience. The biggest reason why this still exists as diagnosis is it has to do with the fact that people are accessing hormone treatment or surgery. So if you're an American in the US healthcare system, if you're going to perform a surgery or you have to put an ICD-10 code. It'll be the same with our medical aids. So the codes exist to be able to access treatment, but it's a little bit controversial because it still makes it look like we are diagnosing people with something that's actually just normal variety. So as part of this also in 2021, the World Association of Sexual Health brought out a specific statement on gender diversity and specifically around the rights of gender identities and gender expressions and bodily diversities and the rights within sexual health care specifically. And then of course in South Africa, actually, although our SA constitution doesn't mention gender identity, it just mentions gender, there has been situations in court where it has now been established through precedent that when we say we protect everybody's sexual orientation, gender, etc., this includes our gender diverse community. So they're protected under law in South Africa. So when we talk about this key population, we're talking about a population at risk. And when we talk about those key populations, our transgender people are more vulnerable than any other of our key populations. They have a much higher HIV prevalence, somewhere between 42 and 49%. And again, we don't have enough data. They have an increased risk of HIV transmission. There's an increased risk of mental illness. They're one of the groups with the highest rates of suicide. There's an increased risk of substance abuse. And there's an increased risk of gender-based violence, much more than any of the other genders. So when you start looking at the data and the stats, the little bit that we have, and it's usually part of studies done on your gay communities, and then there'll be little subsections on transgender. And the stats are quite horrifying. And one of the conclusions they found that is the reason why they have these terrible outcomes is mainly to do with discrimination and systemic biases. So the nightmare of living as a transgender person is you literally have this big sign in neon on your forehead. If you're gay or if you're a sex worker, you can show up at a clinic and nobody will necessarily know that you're gay or a sex worker unless you disclose. So there's a lot of people in the workplace or in our lives, in our schools that might be gay, and you will not be aware of that status unless they decide to disclose it. But if you're transgender, unless you're able to pass, so that's one of the concepts, transgender people hope that nobody would notice that they're transgender, we just consider them either male or female. But many of them, especially if they haven't had the help of hormones and if they haven't had the help of some of the things you need to be able to make you look more male or more female, everybody can see that they're transgender. And therefore, every single time they interact in the world, whether you're going to a new party, whether you're going to the mall, whether you're going to a shop, whether you're going to a healthcare facility, there's always the possibility of a reaction. So there's this constant anxiety and fear as a transgender people, because you're literally walking around with this big sign saying, here I am. And so when they've looked specifically also at healthcare facilities, they find that healthcare facilities in that way can be also quite exclusive. So trans people do not feel welcomed when they walk into healthcare facilities, or certainly not affirmed for their genders. And there's a lot of prejudice, stigma, transphobia, discrimination, and you can't hide from it. You can't pretend that you are something that you're not. So there's also been a study done by Muller, that was not me, it's a different Muller, looking at SOGI, so that stands for sexual orientation, gender identity, and looking specifically at healthcare access. A lot of people feeling they've been treated with less respect because of their SOGI, either even been called names or been actually insulted in facilities. And actually being denied healthcare because of this. And I want you to imagine small rural clinics where there's still strong cultural, religious views from your healthcare professionals, and that difficulty of looking after some of these people. And so the problem is that we don't see transgender people in our clinics. They don't come for contraception, they don't come for condoms, they don't come for PrEP, they don't come for any of our HIV testing, they don't come for services. And that is the biggest reason why they have such high levels of risk. So this is just also another interesting survey that was done. I like the title there. It was called Progressive Prudes, done by the Human Sciences and Research Council, looking at South Africans' attitudes towards the LGBT communities. And I just want to highlight this one little thing. And this just tells you about what South Africa is all about. And actually, this does give me hope. So 51% of all South Africans in that particular study do believe that, you know, gay or gender should have the same rights. It should not affect the rights of the gay people. But at the same time, 72% of them believe that being homosexual is morally wrong. So we have this, and that's why they call it progressive prudes. We have this amazing thing in South Africa that people have their own cultures, their own identities, their own beliefs, and yet are able to respect the culture and the beliefs of somebody else that's different than them. And I think we have that very strongly in the healthcare facilities. So in our healthcare facilities already, we are becoming more and more able to provide services to a wide range of community, even if our own, without feeling that we are in some ways negating our own beliefs or our own ideas or our own concepts in terms of things like sexual orientation and gender identity. So let's get a little bit out of the guidelines themselves. So the reason why the guidelines came out is this recognition that all of these factors makes them much more vulnerable to health risks. And so how do we provide access of care to our transgender communities? So our transgender population, that's one of the photographs from that amazing non-binary photographer that was at the Tate. Our TGD population is not like our gay population. They have completely different needs, and there's different concepts around caring for our TGD populations. So I'm going to go through a couple of concepts or terms that gets used in that world. And the one that you'll hear most commonly is gender dysphoria. And if you speak to transgender people, they know this term and they use this term to talk about their experiences. So gender dysphoria is the psychological or physical distress caused by the incongruence between the sex assigned at birth and the gender identity. So somebody looking at their body and going, this is not the body I'm supposed to have with how I see and feel and identify with myself. What's interesting is not all TGD people necessarily have gender dysphoria. So you can have a trans person who's quite comfortable with some of the bits they have, happy to adjust some of the other bits they have, and is quite comfortable and just living a transgender life. So gender dysphoria is not a necessary symptom to prove that you're transgender. It's almost just a symptom of being transgender in some people. And as I've mentioned earlier, the only reason why this term actually exists at all is for administrative purposes for HRT and for surgery. Because gender dysphoria it's not a mental illness. It doesn't have a whole list of criteria in terms of mental illnesses. So the opposite of the counterpart to gender dysphoria, or sort of almost the way to manage gender dysphoria, is the concept of gender affirmation. And this is a very wide concept. So gender affirmation is an adjective used to refer to behaviors or interventions that affirm a transgender person's gender identity. So using the correct pronouns is gender affirming. Using the name that person, quite often they change their names, using that person's name is gender affirming. Changing their marker in their ID is gender affirming. So anything that affirms the gender that they say that they identify with is gender affirmation. So when we're talking about gender affirmation, we're looking at a much wider concept before we're talking about surgery. And it's interestingly, when you talk about gender affirmation, everybody thinks about surgery. Well, actually, surgery is a very, very, very small aspect of that. So the South African HIV Clinician Society, when they brought out the guideline, they specifically talk about this depathologization of TGD and to adapt an affirmative stance towards gender diversity. So the guideline itself is a very positive guideline towards creating services. In terms of discrimination, there's quite a lot of terminologies we use around the stigmatization that is experienced by our transgender. So on the most basic level is misgendering. And there's been particular in that study that they were doing about healthcare workers' attitudes, they had focus groups as well. There was descriptions of a nurse refusing to use the correct pronoun or refusing to use their name because this is different than the one in your ID and I will use what's on your ID and I will have only what's on your ID on your notes. So that is called misgendering and is very painful to trans people. Microaggressions is not just in transgender, it's subtle forms of discrimination. It's the raised eyebrow that communicates hostile or derogatory messages towards trans people. And as I've said, because trans people are so visible, depending also in the culture they live in or the community live in, some of them experience microaggressions every single day. Every time they go out, every time they have to interact with anybody, they have to deal with that they've now just come out to a stranger as being transgender. And this is, I think, one of the big things that contributes to this massive issues of mental health and anxiety that we see. And of course, transphobia is the extreme of it. It's a bit like the racist version of people who are actually have discussed fear, hostility, and there's actually violence sometimes specifically towards transgender people or people who do not conform to our ideas. So the South African HIV guidelines has looked, the reason why the guidelines was created is how can we get transgender people to come to our clinics? How do we create gender affirming care? And part of the gender affirming care is obviously providing hormones. So we'll talk a little bit about that. But a large part of gender affirming care is how to create services that affirm the gender of our client and makes them feel safe to come to us. And the idea is once we've created a safe service, then we can provide HIV services, STI screening, PrEP, and all the other things we want to bring in to help keep our population safe. So the guideline gives excellent guidelines. It's very well written. There's a short version and then there's that expanded version, which is literally like a book. And is a very thorough introduction in how to provide a comprehensive package of gender affirming services. So when you look at the guidelines, they actually have the whole first chapter is dedicated to the values that they have that underpins this, which is very much based on affirmation, dignity, equity, etc. And of course, our Barto Pele principles. And when you look at gender affirmation, there are, as I've said earlier, there are lots of different domains. So there's your social domain. This is where calling a person by the correct name, using the correct pronoun, being able to, one of the challenges is what happens to toilets? Which toilet do they go to? So this is a real issue. I was on holiday with 3 trans kids recently, and we were camping at Treneries. And now you have the bathrooms, and well, tickets were non-binary. The one was trans, and he was very nervous about being misgendered. Young boy, 16, 17 years old, not yet on hormone therapy. So if he goes, he dresses like a boy, but if he goes into the female toilets, the woman will start misgendering him as female, right? So he suddenly now is classifying. But would you let your child go into the male toilets? Was assigned female at birth? So we had this real experience of this trauma of this child almost not wanting to go to the toilet. So going really, really late at night when nobody was around, or trying to find a way around safety. And it's interesting, in the UK, for some reason, toilets is the big thing that's always in the newspapers around transgender people. And all the issues around toilets are cisgendered people being nervous about transgendered people coming into their toilets. But cisgendered people are not the ones at risk. The people who are at risk is the transgendered people using these toilets and finding either being misgendered or at worst gender-based violence in those scenarios. So very, very vulnerable. And how do we create friendly spaces for that? So psychologically, how to create specific services that keeps people safe. Keeps people supported, and how to have psychological services to support the process that trans people go through. So being trans is not a diagnosis, but being trans makes you extremely vulnerable to live and negotiate in the world of today. And so we need specific psychosocial support to help accompany and support that process. The medical, we're going to look a little bit at in more detail. That includes hormone therapy. It includes, of course, surgery. There's a 25-year waiting list of surgery, so we're not even talking about surgery. Also, things like voice or speech therapists can get involved to help, especially the trans women with their voice, and preventative services for our trans people. And then there's all the legal sides of gender affirmation. Sometimes doctors might get involved in that. So if you don't have to go through transition full surgery to be able to change your gender marker on your ID, but you do need 2 letters from a doctor. I think there's even a format in the guidelines to show you how to do that. So you might have to get involved as a medical practitioner for a trans person to be able to go and change their gender marker on their ID at Home Affairs. So one of the important things that's changed in these guidelines is that this concept of gatekeeping versus informed consent. So what used to happen is, under the old days when we had it as an identification disorder, is the doctor had to decide if this person was trans enough for treatment. The doctor had to decide, is this person sick enough or distressed enough to get treatment? So there was a whole focus on the doctor making a decision about the identity of the human being. Now the focus is much more on informed consent. Your role as a doctor, the person comes to you as transgender, wanting to go through transition, and you as a doctor need to make sure they know exactly what they're letting themselves in for. So if you take these hormones, these are all the things that's going to happen. This is what's reversible. This is what's not reversible. Have you thought about this? Have you thought about that? So there's a large focus in the guideline on informed consent. And they've even included in the back 2 leaflets, information leaflets, both for trans women and trans men, that you can work through with them to go through all the things they need to know. In the guideline, they work through lots of different components. So as Doc said, chapter 6 is specifically on medical therapy, but they've actually got chapters on a whole lot of different aspects of gender affirmation. And I just want to talk about primary and preventative care. So one of the challenges is the reason why the HIV Clinician Society brought out the guideline is to bring trans people in so we can provide these services. We want to be able to take care of them if there was violence. We want to check their mental health. We want to talk to them about fertility and provide contraception. We want to do all their cancer screenings. We want to do sexual health and STI screening. We want to do HIV testing. We want to give them PrEP. The idea must be is that the services are supposed to be integrated. So you use hormone therapy to make trans people feel more safe to come to your facility so you can provide all of these services. So we'll talk a little bit more about that later, because at the moment, hormone therapy has been put under the care of the endocrinology internal medicine department. But we don't want to split these services. We don't want people to go there because the whole idea is you want a combined package. And we certainly don't want medicine department to start prescribing PrEP and doing all of that. So for psychosocial care, very important to have counseling and psychotherapy available, and it must be counselors and psychotherapists that understand what the trans person is going through. But very important, to go through transition, you don't need a psychiatric assessment because you don't need a diagnosis. So you don't need a psychiatrist to tell the doctor that, yes, this person is allowed to go on to therapy, but we want psychosocial support for somebody who's busy going through transition. So medical therapy, there are 4 components. I'm going to talk about the first 2. There's hormone therapy for feminization. There's hormone therapy for masculinization. There's puberty blockers for adolescents. So some of that is already happening at Frere Hospital in our pediatric department. I think Dr. Levi was involved with the first person who was championing and working with that. And I'm not going to cover that today. And then fertility preservation through gamete storage, which I don't think is an option at all in the public sector. So I'm not going to cover that either. I'm just going to talk about the first 2. So in July of 2021, on the tertiary and quaternary level essential medicine list, we now have gender treatment affirmed. It's been shown to be safe and effective. It's not much worse than prescribing hormone therapy for your postmenopausal woman. It's been approved. I'm not sure about regional level of care. We can talk about that at the end. I just realized it says tertiary and quaternary, so I'm not sure where that leaves CMH. And as I've said, it's all based on informed consent. So your role as a clinician in those scenarios before you prescribe those hormones is knowing that the patient understands what's going to happen. And the goal of the treatment is to affirm the client's experienced gender. So this looks very familiar because this is how we do medicine. So that's just, I'm going to go through some slides separately. You will obviously have a discussion on all the things that they're going to expect. You're going to work with your multidisciplinary team. You're going to do a basic baseline assessment, which will include an examination and some bloods. For feminizing therapy, so your trans women, we're going to be using estrogen with or without an anti-androgen. For masculinizing therapy, we're going to use testosterone for our trans men. And then you obviously have to monitor and follow that up. So what does that all look like? So firstly, our indications for gender affirming therapy is basically the trans person coming in with a desire to use hormone therapy. So it's driven by the client, it's not driven by the doctor. And there must be persistent gender incongruence. So persistent is always a vague term. I think 6 months is sort of the standard. So you should have at least felt like you're transgender for more than 6 months. You can't wake up one Saturday morning and decide on Monday to go on hormones. And you need to be able to make fully informed decision and be able to consent to treatment. So when one talks about puberty, that's where issues around consent becomes a discussion. And we're not going to cover that. I think that's a whole section in its own right. But certainly in an adult, you want to make sure that they understand what they're letting themselves in for. So you don't have to be gender dysphoric to qualify. You don't have to be depressed. You don't have to have a severe distress. You just have to request. And if you do have a significant other medical, so quite a lot of trans people can have high levels of anxiety or might even be depressed. You do not try and first sort out a mental health problem before you start hormone therapy. So you will do them both concurrently. So you'll start the hormone therapy, which will actually probably be helpful. And at the same time, you obviously have to manage the mental health condition. Before starting hormone therapy, we do like to have a psychosocial assessment. But interestingly, it says it can be done by a qualified health professional, which could be the prescribing clinician. So the guidelines does not expect you to send the patient to a psychologist or to a psychiatrist to be able to get treatment, but we would like them to be part of a psychosocial support system before they go through transition. So it's that you can feel how the emphasis has shifted in terms of how we use our psychologists for this purpose. And we would have to look for our psychologists in like a Frere or CMH setting eventually when we have these conversations in terms of how comfortable they are in dealing with TGD communities. So when you look at informed consent, these are the things you're going to tell your patients. We're going to look at the effects in a minute. So we're going to look at what happens and how long it takes to happen. We obviously want to know what risks and side effects you're going to have now that you're taking hormones. And a little bit think prescribing pill, prescribing HRT. There are risks, but they're relatively small. obviously the benefits that will come from going on it. Some effects are reversible and some are not. You will generally find your trans people knows better than you what's going to happen on hormone therapy and how long it's going to take. That's the first things they look up. How long it's going to take. Very important to manage your client expectations. So if you are going on to estrogen, you're not going to turn into Marilyn Monroe. So the feminizing therapy is going to work with your own genetics. So depending on what breast sizes are in your family, that's the breast size you're going to end up developing. So the idea is that you can't predict exactly what those changes are going to be because that depends on what's genetically predetermined. It's a bit like at puberty. When your child starts going through puberty as a girl or a boy, you can't predict, you know, are they going to be a big muscly guy? Are they going to be a thin, scrawny guy? Or exactly what that's going to look like. Very important, you've got to talk about fertility. So going on testosterone and estrogen on the long run certainly affects fertility. It's not 100%, so you can't use it as contraception. You have to talk about contraception as well. But there is a large risk that they will become infertile. So you have to have a conversation about what they call, do you want your genetically own offspring? Because obviously there's lots of ways of having a family without it being from your ovum or your sperm, but that option needs to be discussed. And in private, obviously, they will talk about the preservation of either sperm or ova for future use, but we don't have that as an option. And then you obviously have to talk about what kind of preparations are available. I'm not going to cover this stuff in detail because you're not doing these services at the moment. And it's the kind of thing you'll look up and train on if we ever get to the point, if you ever get to a point where you are involved in these services. But the principles are very similar to prescribing, for example, HRT to a post-menopausal woman. You're going to take a good history of the kinds of things that might put them at slightly higher risk going on to hormones. And then you do a good examination. And very important, you don't need to examine the breasts or the genitals, or it's not important. You want to just look at the medical side of it. And just to be aware that trans people are often triggered around things around their sexual organs and their sexual, so around breasts, there can be a huge sensitivity and it has to be managed very sensitive. So there's no reason to undress the patient from top to toe when you do your examination. For your lab investigations, I'll just emphasize that even put a little resource restraint, and these are the basic bloods you will do at the beginning. HB, especially in your men, who's going to go into testosterone, creatinine, and potential, it'll be nice, yeah, we will be monitoring potassium as well for our trans women, ALT, sugar, which you can just do a point of care, and your total cholesterol because of the increased cardiovascular risks. Of course, if they were born female at birth, you would want to do a pregnancy test, and then there's some sexual health stuff. So you're pretty much a basic standard workup. And then the way we manage these patients is, again, it's treat to target. We like those, hey, treat to target, find a target. And the target is not the changes. So everybody's going to be different. You can't go, okay, we'll go until your breast size is a cup D and then maybe we'll finish. We're purely going to look at what the blood levels are of the hormones. So your patient's going to literally go through a second puberty, and there's no ways to predict exactly how long that's going to take and what they're going to actually, what characteristics they're going to develop to what extent by the end of that. So we're only going to look at the hormone levels in the blood. So you're going to look at, for trans men, you will look at testosterone, and for trans women, you will look at estrogen. And you basically want to get, so if it's a trans man, you want to get the testosterone levels to the normal levels for a man. And if it's a trans woman, to the normal levels for a woman. So your normal values you're going to use is the values on your NHLS form. So the easiest way to do it is when you take your blood test and it's a trans man, make sure you tick male on your NHLS request form. And when they give you the testosterone level, they'll give you the normal values for men. And that's going to be your target that you're going to be working towards, and the same for estrogen. So in feminizing hormone therapy, we are obviously trying to produce feminizing sexual characteristics, and your main drug for that is going to be estrogen. But, and I'll explain a little bit more in a minute, you also might have to suppress the effects of endogenous testosterone. And in our setting, that's usually spironolactone. So this has a little bit to do with when you take estrogen orally, it has to go through the first pass effect. It has to actually go through the liver, creates estrone, and that estrone on too high dosages is where your risks for VTEs really come in. So DVTs and things like that. So the challenge is when you have oral estrogen, you've got a ceiling on how much oral estrogen you can actually give, or you're going to have an unacceptable increase of risk. And therefore, to balance the testosterone, if you have high enough estrogen, it will actually suppress the testosterone, but you can't use quite that high levels of estrogen because of the risk. And so you're also going to give something to actually bring down your testosterone, which is the spironolactone. Progesterone, there are some people who use progesterone. There's actually, we need much more data on that. Certainly preparations like Depo-Provera is not helpful and is not indicated, although you might sometimes use it in a trans man where the testosterone is not completely dried up the period, and then you can use that also as a contraceptive method. So if you get your estrogen high enough, as I've mentioned, it will reduce your LH and FSH and will reduce your testosterone. The problem is you can't quite get enough estrogen on board unless you give it parenterally. So in the private sector and in the NGO sectors, in the big programs in Joburg and Cape Town, they like to use estradiol valeriate, which is IMI or subcutaneously. But as far as I know, we don't have access to that in our public sector. So most public sector facilities, and actually quite a lot of facilities, the two choices we basically have is our estradiol or estrofem and Premarin. And for each of them, they give you very nicely the starting doses. We'll talk about how you increase. You've got a maximum maintenance dose and a possible maximum dose that you can give. So when you think about the oral estrogen preparations, if they're oral, then you're going to probably end up having to also give spironolactone. It's not as safe as the parenteral treatment because of that first pass effect. And there is this dose limitation because of the risk of VTE. So your side effects is very similar when you're counseling a woman going into HRT for postmenopause. Migraine, nausea, mood changes. Some of those actually settle down once the libido is set down, changes to libido in the sexual response cycle. So important to realize sexual desire does not necessarily, there's different types of sexual desire, and the sexual desire might change. It doesn't mean you don't have a libido. It just means your libido behaves differently. I've got a talk on sex if any of you are interested on that side of things. And the two drugs we have then is estrofem, which is, I think, if you have that available, that's usually the first choice, or Premarin, which is not quite as good as the estrofem. So those are usually the preparations that are being used. As far as I know, Premarin at the moment is out of stock. I know at CMH, we've got the estradiol 1 milligram tablet available. So the risks and the side effects, again, if you think HRT, is mostly our concerns about thrombosis, so rare cerebrovascular events, deep vein thrombosis, pulmonary embolism. When you assess your patient, you're going to look at all those typical risk factors like smoking, diabetes, hypertension, etc. Take that into account and counsel your patient accordingly. And there are specific contraindications. So obviously, if they've got a previous VTE, especially if it was an unprovoked one, or if they're in a hypercoagulable state, not a state. If they have obviously an active sex hormone sensitive cancer, and if they've got advanced chronic liver disease. So there's not that many contraindications, but there are some things to be aware about. In our anti-androgen, which you're now going to add, because we're going to use an oral preparation, as we've said, so spironolactone, which we're all very familiar with for all kinds of other reasons. Usually the dose is about 50 milligrams, which I think we're quite used to also giving. I see they can give a maximum dose of 200 milligrams. I've never used that much spironolactone, but that might be limited by your side effects. So spironolactone, obviously our risk is hyperkalemia. So that's why you check your kidneys before you start. And every time you adjust the dose, you've got to check that potassium within 2 to 4 weeks, like we do for our cardiac failure patients as well. And you have to be careful, obviously, if your patient's on an ACE or an ARB, just like we are for our CCF patients. And there's a list of possible side effects on spironolactone. So this is always the interesting slide, right? This is the one that all they want to know is they want to know this. How long does it take and what can I expect? So you will notice that most of the effects are actually reversible. So once you stop the HRT, most of those effects will go away, which is not so happy for the patients. So they have to be on this treatment for lifelong. And these are the kinds of things that happen. So you get body fat distribution, so you have more of that hourglass. And you can notice here, it will take a while to start and it can take a while to get maximum effect. So you might get them onto the right hormone level within 2 or 3 months. So you know they've now got normal, and now they have to go through puberty. So if you were to measure the testosterone in a boy of 12, 13, his testosterone levels have now gone up to adult male levels, but it's going to take 3, 4, 5 years for all of those effects to take place. So it's the same scenario here. So it's going to take time, even when your hormone levels are now up to the right levels. Decreased muscle mass and strength takes a couple of years, the skin goes kind of softer. So this change in sexual desire is quite important. They need counseling around that, as well as decreased erections. So just because you have less spontaneous desire does not mean you have less desire. Your desire might just behave in a different way. Oh, and this button. You have breast growth. It's probably the most important and the most helpful in terms of gender affirmation for your clients. That takes 3 to 6 months before you even start getting breasts growing. And it can take a full 4 years before you know, okay, this is now my breast size. So for example, if they do breast augmentation, we've got a 25-year waiting list, so it's not really a question. They will wait till those 4 years are passed before they will now actually look at breast augmentation. And again, the size of your breast is going to depend on your genetics, not on the amount of hormones that you're on. It just depends on your own body. There'll obviously be decreased sperm reduction, decreased terminal hair growth. You might get some scalp hair back if you were going slightly bald. And what's interesting and important is that the voice doesn't change. So in the men, the trans men, the voice does drop, but trans women, the voice does not drop. And this is an issue. So sometimes they look like a woman, and as soon as they speak, the voice is very deep. And so quite often for this is where the speech therapists get involved and actually use speech therapy techniques to both lower the voice or make the voice more feminine in the way that they use it to be able to pass more easily. Great. Masculinizing treatment. So oral testosterone are not usable for HRT. We don't use them in other contexts really either, partly also because of they don't actually provide adequate masculinization because most of it gets broken down before it reaches the target. So we always use injectables. And those are our 2 preparations that's in theory available. I think the Depo is the one that's been out of stock globally at the moment. There's been some problems with supply. So Depo testosterone is probably the commonly used one if it's available, because you can give it subcutaneously. So you can do it yourself every week or 2 weeks. And then you've got a 10-weekly one that is 1,000 milligrams and 4 mils, which is an IMI injection every 10 to 12 weeks. And again, it gets built up. So the 12-weekly injection, you don't actually up the dose. You just shorten the dose interval until you're on target. So this is the long-acting one, the one you get every 10 weeks. This one is definitely also a bit more expensive. And it's a bit more trickier to get your target dose right because you're getting this injection every 10 to 12 weeks. The short-acting one is a little bit cheaper, and you have to give it more often, and it's much easier to end up getting your level right. Side effects on testosterone, there's ones we worry about and ones we don't worry about. We obviously don't worry so much about the acne, but the patients need to be aware. But for your context, the patients you might see is that, remember, if you are assigned female at birth, your estrogen protects you to some extent against cardiovascular events during your fertile years. So if you take that protective effect, other way around. Because you're adding estrogen to somebody, you are now, I was right. So you're a trans man, you were assigned female at birth, we're removing your estrogen. And so now what's happening is your risk goes up to the same risk as a man of the same age. So because you now also have testosterone levels and you don't have estrogen, you're going to have the same risk as other men for hyperlipidemia and hypertension. The only one is quite interesting and might end up in your MOPD is patients who develop polycythemia on testosterone. So the contraindications is pregnancy. So we test for pregnancy before we start testosterone. Again, if they've got a sex hormone sensitive cancer, and if they've got an untreated polycythemia with a very high percentage, and obviously that's relatively easy to manage. So again, the slide that they're all looking for always is how long will it take to turn me into the body that I identify with. So acne starts quite quickly and it's like teenage years. So it comes into maximum effect and that quite often settles down anyway, a bit like teenage boys' skin does clear up eventually. So they've got, so the big thing that just like your trans woman would like breasts, your trans men would like a beard. So the facial and body hair growth starts between 6 and 12 months, but it can take a full 4 to 5 years for your full beard to come in. And just like any man, depending on your family, you might also then get your balding like any man would, depending on your family. So if you've got men balding in your family, and you're on testosterone, then you might also bald. If your men don't go bald, then you might not either. So they also have things like increased muscle mass and strength. Now, this is interesting because not every man with testosterone has got a big body. So you've got to combine this with exercise. So the testosterone helps you to build bigger muscles and more strength, but you actually have to combine it with a good bit of gymming if you want to get the pecs and the abs and all of that. Fat distribution, so getting more of that straight shape. Menses, not always seizures and is not always reversible. You do get some clitoral hypertrophy, so in some cases up to 4 centimeters, but that's sort of your more in the minority of patients. One of the challenges is vaginal atrophy, and quite often that gets treated then with local estrogen creams, just in terms of symptom relief. And they do get a deepening of voice, and interestingly, that is not reversible. So the voice does deepen, and the voice box actually changes. So how do we follow them up? So hormone testing actually only happens until they're on target. So you don't do a hormone at baseline. You do a hormone at 1 month, at 2 months, you adjust your dosing, depending on what preparation they're on, and then on 6 months. And then if they're on target, you don't have to repeat your hormone testing. You still want to see them roughly every 3 months in the beginning. You're mostly checking on how they're doing, where they're at, if there's any side effects or risks, think contraception. And thereafter, you literally only need to see them every 6 or 12 months for the script. So again, think contraception. We are not actively treating something like diabetes. So it's the monitoring should actually be minimal. And once they're on target in terms of hormones, you don't need to redo the hormones. There are scenarios where you might decide. So if they decide to have surgery, you might check the hormone profile, or if they suddenly feel that for some reason they're starting to defeminize or just to virilize, then you might check what's going on. And there are your follow-up bloods. Again, I wouldn't worry too much about this because you're not using it at the moment, but you might eventually. But basically with your spironolactone, you're obviously going to keep an eye on your potassium. If they're on masculinizing treatment, we check our HBs for that polycythemia. For both of them, you'll keep an eye on your ALT. And again, that's in the end will only be an annual blood test once they are settled and stable on treatment. Gender affirming surgery, for masculinizing, the big thing is always top surgery. So double mastectomy, phalloplasties, metoidioplasties, even in USA is actually still very uncommon. And feminizing, the main thing is breast augmentation. And as I said, in South Africa, very long waiting lists and challenges both in public sector and private care. Most patients can actually feel very comfortable just on hormone therapy. Hormone therapy gets them far enough. And only about 30 or 40% of trans patients even would consider surgery. So not every person that's trans necessarily wants to have an operation. The hormone therapy are usually more than enough to help them feel more feminine or more masculine and help them to pass in the society that they live in. So the other things that I've mentioned already is the speech therapy. And then you just need to be aware of something called non-medical gender affirming practices. So there are ways to try and make your body shape look more male or female. And there are very unsafe ways of doing this. So this can be problematic if you don't have somebody that can advise them on how to do this safely. There's lots of YouTube videos now on all of this. So binding is when you're binding the breasts. So the not safe method is doing with duct tape. But there are actually particular bras one can wear to flatten the breast shape. And there are particular ways of taping the breasts flat that is less damaging to the skin, for example. Packing is the classic sock in the trousers. In terms of getting a silhouette there, I guess would be the right word. Padding is when you're augmenting the breast through putting in extra bits. And tucking in men is, again, similar to the binding, is when you tuck the penis out of the way. Also, duct tape, not a good idea. So there are safe ways of actually doing tucking. And being sensitive about those kinds of topics and advising people on there's good leaflets and there's good videos on how to safely tuck and bind is quite important. And quite often, this is all patients have. If they don't have hormone therapy, these are the kinds of things that they need to do. And even with hormone therapy, it's not going to remove the breast, it's not going to remove the penis. To change the silhouette, they will use these different methodologies. Peer support groups, Zoom has revolutionized the world. So there's an amazing online organization called Be True, looking after gender diverse communities, and they have amazing weekly support groups for a whole range of different groups. And then lastly, talking about structural interventions. So how do we make our structures more? So this is literally my last slide. We're not yet at the point of looking at, before we start looking at creating services that has all these fancy things in place, the most basic thing is how do we make our healthcare facilities in general more trans friendly? And some of the structural things we can look at is just being able to train even our front desk that we call our patients by the preferred name. So if you've got a file and you have a number and it has to be the ID number, you can still have a massive preferred name at the top, which is the name we call the patient by when we call the patient. Changing the gender marker on the file. So if there's an issue that you actually do need to know the biological gender of the patient, because that's important for medical reasons, like whether I need to do a cervical screen, you can have a category of having a biological sex and a different category for gender identity. And when we call our patients or address our patients, we use their gender identity, not the biological sex. It's a very simple way to make a service more affirming. Gender neutral bathroom, tricky. So at my facility, we're busy looking at the moment. I have a staff toilet that's both for men and women, a single toilet, and we'll make that available for people who need a gender neutral bathroom. Do remember, we're not talking great numbers. We don't have trans people streaming through our facilities every day. You just need to have some sort of thing available for every now and then when somebody comes in. And even just having a sign on the wall with a saying, this is where the gender neutral, with the transgender sign at the top is already giving a message that we are sensitive to the needs of our transgender. And then the biggest thing is training our staff, from the security guy who's at the front to the person who gives out the file to the nurse who sees the patient, in terms of how we address and work with transgender facilities. And that can already create services that are just a little bit more friendly than what we have at the moment.